Good afternoon, everyone. Our hard work this semester has brought us to our final presentation, and today I'm going to talk to you about the effect of quiet time on delirium in the adult ICU. Sleep is essential for physical and mental well-being, and in critical illness, it aids in restoring health and overcoming illness. Critically ill patients need their sleep, and unfortunately, it evades them for a variety of reasons. Now, there's long-term and short-term effects of poor sleep, which include poor cognition, increased susceptibility to infection, cancer, and cardiovascular disease. ICU patients suffer from frequent sleep disruptions, partially because of the ICU setting itself. There's a lot of noise in this hectic environment. There's equipment, alarms going off, staff conversations, noise from other patients and from visitors, which disrupt sleep. Artificial lighting used in the intensive care unit is not conducive to sleep. Frequent care provisions, which we need to do, but unfortunately are sleep disruptive, as are the visits from healthcare staff and from family. Critical illness is not conducive to sleep. Pain and anxiety are often associated with critical illness and unfortunately are sleep disruptive, as is the equipment used to treat the critical illness and the medications given to treat the critical illness. Now, increased cortisol levels that rise in response to the stress of critical illness encourage wakefulness and unfortunately are sleep disruptive. So we know that the ICUs themselves are noisy places, and unfortunately noise within the patient rooms often exceed the guidelines set forth by the World Health Organization. Patients complain of noise in the ICU setting, and we believe that this contributes to sleep deprivation. Now, sleep deprivation has been known to reduce respiratory muscle strength. This reduces sensitivity and intrinsic response to hypoxia and hypercapnia and may contribute to hypoventilation, which unfortunately eventually leads to prolonged assisted ventilation. There's a release of catecholamines, adrenaline, and noradrenaline, which increases blood pressure and heart rate. And in the critically ill, as we talked about before, the cortisol levels are high in response to stress. Along with this is a suppression of melatonin, and this can exacerbate catabolic activity and oxygen consumption, putting a greater demand on the patient. There's also an impairment of carbohydrate resistance, which leads to insulin resistance and glucose clearance, which may exacerbate underlying conditions such as cardiovascular disease and diabetes. Delirium affects 12.5 million patients annually, increasing medical costs by $152 billion. The American Psychiatric Association defines it as a syndrome of cognitive dysfunction characterized by disorganized thinking and the inability to maintain attention. Now, in the general hospital population, the incidence is about 15 to 50%, but when you go into the ICU, it increases to 20 to 80%, with mechanically ventilated patients exhibiting the highest incidence. The cause is often considered to be multifactorial, but it is believed that sleep deprivation is a contributing factor. Delirium is an independent predictor of adverse patient outcomes and is now considered to be the most common ICU complication. It's associated with a variety of complications, including nosocomial pneumonia, self-extubation, reintubation, cardiopulmonary edema, cardiac arrhythmias, and catheter removal, all of which increase length of stay. It is also associated with increased ventilatory support days, the development of chronic cognitive dysfunction, increased inpatient mortality, and increased rehabilitation needs post-discharge. So in looking for my PICO question, I knew that we had a disruptive setting and sleep deprivation contributing potentially to delirium, as does the insult of critical illness. There's common ICU medications such as benzodiazepines, opioids, diphenhydramine, trazodone, which have their place in the ICU. For sure, we use them a lot, but they can also contribute to sleep deprivation and delirium. So unfortunately, because of all of these factors, there's a limited number of research studies which have been actually conducted in the ICU. So basically, I found a gap in the literature when I was attempting to connect the variables. So I developed a PICO question based on this gap, and my PICO question was, in critically ill adults, does the institution of quiet time periods compared to no quiet time periods reduce the incidence of delirium during the ICU stay? So I move forward from my PICO question, taking it to the literature search, and you can see here the list of databases that I used to try to research. And when I did find articles, I did do some hand searching of references in the retrieved articles that were applicable to my PICO. You can see here my list of keywords. I note here not farm. That was part of my original search strategy, but finding studies that don't incorporate some implications from pharmaceuticals in the ICU is extremely difficult. So there is the use of medications in my studies. You can also see the limitations and the results that I got here. From this, I developed, or I found 3 studies which I felt best answered my PICO question. All the studies took place in adult ICU settings, academic facilities, and 2 of the 3 took place in magnet-designated hospitals in the United States. 1 took place in Belgium. Now, these 3 studies all identify the significance and implications of sleep deprivation and delirium as referenced by the literature. And they understand that delirium is multifactorial and probably not going to be eliminated by one single intervention, but they're looking at what effect sleep deprivation has on delirium, and if we can find a way to address a potentially modifiable factor of sleep deprivation, what effect is that going to have on delirium? Is it possible for us to decrease the incidence of delirium? Camdar and Associates conducted a observational pre-post design at Johns Hopkins University Hospital in Maryland in their 16-bed medical ICU with a 1-to-2 nurse-to-patient ratio in that unit. McAndrew conducted a prospective design in a 460-bed level 1 adult trauma care center in the Midwest in a 26-bed medical ICU, also with a 1-to-2 nurse-to-patient ratio. Van Rompuy did a randomized controlled trial in Antwerp University Hospital in Belgium. This was a 625-bed facility with a 45-bed combined medical surgical ICU. Now, this unit was 45 beds, but it was subdivided into 7 to 15 bed units with a 1-to-1 nurse-to-patient ratio. In looking at strength and quality of evidence, I utilized the Johns Hopkins Evidence-Based Practice Strength of Evidence Rating Scheme and Quality Rating Scheme for Research Evidence. Camdar and Associates and McAndrew and Associates both came in with level 3 strength for their non-experimental studies, and Van Rompuy's randomized controlled trial is a level 2 strength. All 3 studies were rated good as far as quality. These studies offered results which were fairly consistent. They were from adequate sample sizes. Conclusions were fairly consistent, and the scientific evidence from their comprehensive literature reviews added support to the findings. Camdar and Associates evaluated the effect of a multifaceted sleep-promoting QI project on sleep quality and delirium in the ICU, and they used a convenient sample of 300 participants for the ICU portion of the study and 38 participants for the post-ICU portion of the study. They looked at baseline data during normal ICU activity prior to the QI project implementation, and they compared that to data after the 3-stage QI project was introduced. They used validated scales to evaluate sleep quality, confusion, agitation, sedation, and severity of illness, and then in the post-ICU portion, they used a questionnaire to evaluate sleep perception and cognitive assessment. A significant improvement in nighttime noise levels was found, as was the incidence of delirium and the number of delirium-free days. Now, McAndrew and Associates evaluated to see if a designated quiet time period in the afternoon from 2 to 4 would reduce the frequency of sedation, sedation levels, and delirium scores on mechanically ventilated patients. They conveniently sampled 72 participants over a 1-year period for their prospective study, and they obtained data from the electronic medical records, which included sedation requirements before, during, and after quiet time, sedation and delirium scores, physiological measurements of heart rate, mean arterial pressure, and respiratory rate, specifically following consecutive quiet time periods. In this study, the quiet time was found to reduce the amount of sedation participants required and to improve RASS scores and respiratory rates after quiet time. There wasn't a statistical difference found in the confusion assessment method for ICU or KMICU method scores. However, 82% of the participants who were cognitively intact before quiet time remained so after quiet time, and 19% of the participants who had cognitive impairment before quiet time became cognitively intact following quiet time. Now, Van Rompuy studied to see if wearing earplugs at night would have an effect on the early onset of delirium and sleep perception. He conveniently sampled 136 participants and evaluated them over a total of 5 nights, maximum of 5 nights. They used randomized computer allocation for group participants, and the study group chose the type of earplug that was worn. They evaluated for agitation, sedation, mentation, confusion, and severity of critical illness, and a blind researcher evaluated the participants' confusion and sleep perception. The participants using earplugs were more cognitively intact, and this benefit continued over a 5-day period. The participants using earplugs showed significant improvement in sleep perception after the first night, and significant findings were also found when you differentiate between delirium and mild delirium. Now, this study used the NURS scale instead of the CAM-ICU scale. Both are validated tools, and they actually had compared the CAM-ICU scale to the NURS scale, and they wanted to use the NURS scale because it differentiated between delirium and mild delirium. Cognitive impairment, combining both delirium and mild delirium, was found in 35% of the study participants, but it actually was found in 60% of the control group. Another interesting finding in this study was that the risk of delirium was noted to increase by 3% for every year of age, by 9% for each increase in SOFA score, and by 87% in patients who were smokers. As we move forward in the evidence-based practice process, we need to bring together the research, evidence, clinical expertise, and patient preferences and values. Sleep fragmentation prevents deeper sleep stages. Methods to improve sleep may reduce the onset of delirium, and multifaceted approaches, which include sleep promotion measures, may be beneficial. Policy implementations should include assessment, prevention, management of delirium, increased staff knowledge, facilitating behavioral change and policy adherence, as well as institutional support and organizational changes for increased efficacy. The clinical practice guidelines for pain, agitation, and delirium management in the ICU recommend the use of the CAM-ICU scale or intensive care delirium screening checklist, as well as promoting sleep through environmental modifications to reduce light and noise, decrease sleep interruptions through clustering of care activities, and promoting normal sleep-wake cycles. Patient preferences need to be taken into consideration. Sleep is important to patients, and lack of sleep is a significant source of stress. Non-pharmacological sleep aids, such as the earplugs, eye masks, and soothing music utilized in the 3 studies that I presented, could be based on patient preference. Offering sleep-promoting measures in the ICU setting are feasible, not likely to incur significant financial cost. So when we're looking at the PICO question of will the quiet time periods potentially decrease the incidence of delirium in the ICU, the evidence from these studies has shown that it may possibly be beneficial in decreasing the incidence of delirium and improving patient outcomes. Implementing a plan to address sleep deprivation and delirium in the ICU would involve the development of a sleep-promoting policy. Daytime and nighttime recommendations would be made. Daytime recommendations would include ambulation out of bed as much as possible, use of natural light, and discouraging excessive napping. Nighttime recommendations would include the utilization of non-pharmacological sleep aids, clustering of nighttime care provisions, reducing bedside alarms, reducing and eliminating room lights. RASS and CAM-ICU scales would be performed every 6 hours and with any change in mentation, as delirium is noted to be a fluctuating cognitive disorder. Pharmacological guidelines to discourage the use of medications known to alter sleep stages and precipitate delirium would be developed. Family and staff education on adherence to the policy would be necessary. Policy development would be done with the assistance of the ICU staff, the critical care nurse educator who would act as the EVP mentor, and the ICU department manager. Formal meetings with stakeholders would include the chief nursing officer, the chief financial officer, hospitalist, intensivist, medical director, as well as the chief of surgery and risk management. This plan would be evaluated through the development of a prospective design study for the purpose of determining the effect of the sleep policy on sleep deprivation and delirium through a convenient sampling of ICU patients with no history of cognitive dysfunction. 1 year of data collection prior to the sleep policy implementation would be obtained and compared to 1 year of data collection following the sleep policy implementation. Validated tools would be used to evaluate sedation, agitation, sleep perception, and delirium, such as the RASS scale, the CAM-ICU scale, and the Richards-Campbell Sleep Questionnaire. This evaluation would include pharmacological agents received during both the baseline and policy periods, and would include daytime and nighttime activity levels, as well as non-pharmacological sleep aids, which would be retrieved from the patient electronic data records. And there are the references for my presentation. I hope you enjoyed it. I look forward to yours. Thank you.